I have a question, actually two questions for the audience. You know, we've heard some really detailed descriptions of birdshot choroidopathy, an eloquent review of the history of it by Dr. Herbert. Why do we call it birdshot? Well, no, you can't possibly know because you're from France and you don't have experience with guns the way we do. So you have to put your hand down. Let me ask in the audience, how many people here have a shotgun? Okay. If you use a shotgun and you have shotgun pellets, what's the effect? Does it look like this disease? It turns out that, you know, I'm from the East Coast as well. And to show you how naive East Coast people are, although I've spent a large part of my life now in the Midwest, when I was at the University of Iowa, my 3 colleagues who were residents in my year said, let's go out to the lot, we're going to shoot some clay pigeons. They said, Hank, come with us. I said, well, you know, I've never had a shotgun before, but sure, I'll come with you. So we go out to this vacated lot. They have their shotguns. I didn't have a shotgun. And they said, Hank, why don't you go in the back of the car and pull out the clay pigeons? So I go to the back of the car, open up the trunk, and I'm looking around. And I know what a pigeon looks like. And I open up this box, and I see these clay discs. I said, well, I can't possibly believe what they're talking about. I mean, if they think this looks like a pigeon, they have problems. And so I go back to them, I say, where are the clay pigeons? Did you forget to put them in the trunk of the car? They say, no, it's those clay discs that are there. So that shows you that 2 people who came from the East Coast, which was Ryan and Momini, had no idea what birdshot looked like either, nor did I. And you know, it was only by being there did I actually realize this. The only other thing I'd like to say before I begin is that, as Steve Foster mentioned at the very beginning, my background is as an immunologist. I was very fortunate enough to actually be the first fellow with Wayne Stryline, who passed away several years ago, and we were involved in really identifying and founding the phenomenon of anterior chamber-associated immune deviation, or ACADE. And so I look at things from an immunologic perspective. And my talk, although it's entitled Cortocosteroid Implant Therapy for Birdshot Chorioretinopathy, will at the outset deviate just slightly. And that is, let's talk about the immune pathogenesis of birdshot chorioretinopathy, because I think if you're going to treat a disease effectively, if you can't identify the etiology of it, that's what's causing it, at least you have to understand how the disease is resulting. And if you understand how the disease is resulting clearly, you'd have a better chance at trying to inhibit it or interfere with it. And so as a result, I'm going to talk about the immune pathogenesis briefly, and essentially I'm going to be talking about autoimmunity, which you heard in great detail from Bob Nussenblatt earlier, so I won't really talk about that in too much detail, but I'm going to talk about autoinflammation and what innate immunity and autoinflammation mean as compared to adaptive immunity and autoimmunity. Then I will talk about corticosteroid therapy, and my views are certainly consistent with what you've heard here. It's something that should be used at the outset of the disease, and in the United States, perhaps except in Boston, where somehow they've been able to influence the insurance companies to pay the expense of biologic response modifiers. In most of the part of the country, we can't get the insurers to pay for it, and therefore it's not available to us. So there may be a role for intermittent pulse therapy of corticosteroids. But let me tell you why. This is probably the most important slide you'll see that I've presented either before or subsequently, and that is, it's becoming apparent now that what we thought was autoimmunity in diseases in general, and probably true in the eye as well, at least we know that it's true, for example, with one disease like Blau syndrome, which is an autoinflammation, that there really is a spectrum of disease that goes from autoinflammation to autoimmunity. And autoinflammation, as I'll explain in a moment, is mediated by what we call innate immunity. And autoimmunity is mediated by adaptive immunity. And innate immunity exists and, in fact, developed to give us resistance to infection. It doesn't have the capabilities of adaptive immunity. but it can respond almost immediately to a microbial pathogen. And in fact, whether most of us like it or not, we're primarily made up of microbes. If you count the number of microbes that are in our body, many more of them than any other particular being. So innate immunity has that particular function. Adaptive immunity evolved to really distinguish between self and non-self. And it's now become apparent that there are some diseases, inflammatory diseases of an organ or of multiple organs, that are solely autoinflammation. And there are others that are autoimmune. And then there are some where there's a combination. And I think what we're looking at with birdshot chorioretinopathy is the combination. I agree with what's been said, for instance, earlier by Carl. And that is, you're looking at two distinct independent diseases. You have a stromal choroiditis, which I believe, in fact, is probably autoimmune and is caused by adaptive immunity. And then you have an inner retinopathy, and I refer to that as an outer retinopathy, because clearly, in my mind, the retina is involved because the photoreceptors are dysfunctional and the photoreceptors die. And I think they die as a consequence of the stromal choroiditis. And then you have an inner retinopathy. And that's where you get the retinal vasculitis, the cystoid macular edema, the vitritis, and I think that's a result of autoinflammation of innate immunity. Okay, what is autoinflammation? Autoinflammation is a dysregulation of innate immunity. And if you look on the slide and you see, I guess we have a new pointer, okay, aha. Okay, if you look at the slide, here you see the elements of the components of innate immunity. Here are the components of adaptive immunity. The two overlap and talk to each other very closely, but you'll notice that in adaptive immunity, it's what you heard from Bob Nussenblatt, is classically are lymphocytes. And there are B lymphocytes that produce a humoral response. There are T lymphocytes that produce a cell-mediated response. In contrast, innate immunity does not have the classic lymphocytes, but primarily has other cells like macrophages, NK cells, dendritic cells, a whole series of granulocytes. It involves the complement cascade. These are elements of inflammation that are not a part of adaptive immunity. And I believe it is these elements which are responsible for the inner retinopathy, that is the vitritis, retinal vasculitis, and CME, and that these are responsible for the photoreceptor loss. And I actually think this is actually shown and suggested by Steve Foster's two recent publications. I'm not sure that I haven't had a chance to discuss this with Steve, but I think that this, in point of fact, explains what he observed clinically. The one thing I do want to point out is that the receptors for these cells are very different than the receptors on the cell membranes for these cells. The receptors in innate immunity are what we call pathogen-associated molecular patterns, or PAMPs for abbreviation. They can exist either on the cell membrane, such as toll-like receptors or C-type lectins, or they can exist in the cytoplasm, such as retinoic acid-inducible gene or NOD-like receptors. And it's the mutation in NOD2 that is, in fact, is responsible for Blau syndrome, which is a disease which has been termed previously juvenile sarcoidosis, but it's a disease that involves the eye. I won't go into this in detail, but just to say that innate immunity is part of the pro-inflammatory cascade, and it can be triggered by these PAMPs, these receptors that recognize pathogens, by DAMPs, which are receptors that recognize endogenous signals, so that when a cell dies and it releases some of its molecular motifs, that they, in fact, can trigger innate immunity. And both PAMPs and DAMPs ultimately result in the degradation of the inflammasome. And the inflammasome, as is discussed here, is an intracellular protein complex that indeed can start an inflammatory cascade. This really isn't in sharp focus, but it shows that IL-1 can form IL-1 beta by caspase-1, which is activated by the inflammasome, and that this then can start the entire pro-inflammatory cascade. In 2008, Steve and Dr. Sorban reported on their experience with daclizumab in the treatment of birdshot chorioretinopathy. And it was a very interesting paper, but the thing that caught my attention was this. And that is, although they obviously reported that daclizumab was really very helpful in stabilizing or improving visual acuity with the resolution of the vitreous inflammation, and in fact, they saw CME resolution, they saw vitritis resolution, i.e. resolution of the inner retinopathy. They had a sentence there, and they had results which caught my attention, and they said the ERG parameters continued to decline despite adequate inflammatory control, and that is they were looking at the implicit time as an example of that. Not only that report, they then went on in the paper that was just mentioned by Dr. Burjan in 2013, looking at their experience with infliximab, and found a very similar response, and that is after initiating infliximab therapy, they controlled inflammation, i.e. the inner retinopathy. And they controlled it in a large group of people, CME resolved. They forgot to leave out a little data in their paper, but I'm sure the data existed because they made the statement that, however, progression of the disease was characterized by the loss of the visual field and electrophysiologic changes. And that's because the outer retinopathy, in fact, was not being treated. And that's because the outer retinopathy, I believe, is a cell-mediated phenomena. And, pass through the hypothesis too quickly. And this is something that I will go through with you in just a little detail, because I think this is really what's going on in this disease. We have proposals, hopefully, that will allow us to study this scientifically, but that'll depend upon whether our government stays open or closed and whether or not the NIH decides to fund it. But our hypothesis is that the HLA-29, or particularly HLA-2902, on antigen-presenting cells, for example, like dendritic cells, from patients with birdshot chorioretinopathy are hyper-responsive in two ways. That is, when they encounter PAMPs or DAMPs, they enhance innate immunity. And when they encounter antigen, they enhance adaptive immunity. A29 is a class 1 MHC molecule. So it preferentially presents antigen to CD8 positive T cells, not CD4 positive T cells. And that's why we don't see the classic inflammations that we normally see in the outer choroid and retina, because I think in the active stage, it's primarily a CD8 positive T cell infiltration. Activated CD8 positive T cells, or cytotoxic lymphocytes, I believe are responsible for the birdshot chorioretinopathy, chorioretinal lesions, or the outer retinopathy. And that's the reason why immune suppression can inhibit the progression. It should be immune suppression, not just immunomodulatory therapy, specifically immune suppression. Innate immunity is primarily mediated by cytokines and interleukins. And that's what's responsible for the vitritis, the retinal vasculitis, the CME, the inner retinopathy. And that's the reason biologic therapy, the modified biologic responders, is needed to inhibit inner retinopathy. Thus, I think for patients with birdshot chorioretinopathy to conclusively have quiescence of their disease, they're going to need immune suppression and biologic therapy in order to achieve the complete quiescence. And it's the reason why only high-dose corticosteroids will inhibit both inner and outer retinopathy. And when we start patients on prednisone therapy, we start them in high dosage. So it affects both the innate and adaptive immune response. But can we maintain them on those high doses? No, we can't. If we do, the side effects, the adverse effects are too dramatic. So what do? We lower the dose of prednisone. You lower the dose of prednisone, and now you're not able to control both innate and adaptive immunity. That was where I was going before I was talking. I was asked to talk about corticosteroids, so I'll talk about corticosteroids next. But so the hypothesis is that the retina and choroid are consistently but independently involved in the inflammatory process, that the innate immune response, or the vitreoretinal features like vitritis, CME, and retinal vasculitis, that limb of the immune response is controlled by corticosteroids and biologics. But that adaptive immune response, that is the chorioretinopathy, the characteristic lesions progress and the gradual visual loss occurs from photoreceptor loss, and that's the limb of the immune response that's controlled by immune suppression or very high-dose corticosteroids. So the first approach to treatment that we almost all use is we start with corticosteroids when we see the patient for the first time, either with or without concomitant immunomodulatory therapy. Since this disease is usually bilateral, and since I think it's obviously systemic in origin, and I think that we need to modify the systemic immune response, I prefer oral corticosteroids. But if necessary to give medication solely restricted to the eye, then in point of fact, I prefer using intravitreal injections of Kenalog rather than the corticosteroid implants Retisert and Ozurdex. But since I was asked to talk about the latter two, I will briefly do so. There are multiple intravitreal devices that the FDA has approved or has in development. The two that have been approved by the FDA for treatment of uveitis are Retisert, which is over here, which is a non-biodegradable intravitreal implant, and Ozurdex, which is a biodegradable intravitreal implant. But there are several other implants that are biodegradable that in fact are being studied right now as potential means of providing corticosteroids for just intraocular use. In terms of Retisert, Retisert has the corticosteroid fluocinolone acetonide. It was FDA approved for the treatment of chronic non-infectious uveitis affecting the posterior segment. It's very small. You can see it right here. It's only 1.5 millimeters. It's a tablet that's coated with polyvinyl alcohol and silicone laminate. And here in reference to some corns, you can see how small it is. It's inserted intravitreally. It measures in length 3 millimeters by 2 millimeters by 6 millimeters. It initially releases fluocinolone at 0.6 micrograms per day. But then its steady state rate reduces to 0.3 to 0.4 micrograms per day, and it's effective for approximately 30 months. The problem with, and when they did the study, what they found that 25% of implanted eyes had a 3-line or greater increase in visual acuity at 34 weeks, and it significantly reduced uveitis recurrences and decreased the need for adjunctive therapy. The problem is, as represented here, at 24 months, close to 90% of patients had cataracts. At 24 months, 30% of patients had glaucoma that couldn't be controlled with medications and therefore required surgery. Insertion of the non-degradable implant requires going to the operating room, and it's non-biodegradable. I do not like using Retisert. I don't use Retisert for those reasons. There are many colleagues of mine who indeed do and have a significant experience with it, but I prefer, if I'm going to use an intravitreal implant, I prefer using Ozurdex. Why? Well, Ozurdex has a, oops, went back the wrong way. Ozurdex has a different corticosteroid. It's a dexamethasone implant. It also is FDA approved for uveitis, for posterior non-infectious uveitis. It's biodegradable, and it's administered via a 22-gauge applicator so that it can be administered in the office. It has a PLGA polymer matrix. It releases 0.7 milligrams of dexamethasone, and the PLGA matrix slowly degrades to lactic acid and glycolic acid, enabling extended release over a 6-month period of time. And if necessary, it can then be used again. The problem is, with both implants, there was no comparative effectiveness trial compared to what most of us, in fact, do with regard to the use of intravitreal corticosteroids. And that is, most of us, before the advent of these implants, went ahead and used intravitreal injections of Kenalog. That wasn't the comparison. That was the standard of care of treatment in the United States. That wasn't the comparison for either study. Well, sure, if you're not going to use the same form of treatment or a comparable form of treatment, you're going to find a beneficial effect to the implant. And therefore, even though the dexamethasone implant showed that there was less intraocular inflammation at 6 months versus a sham procedure, there was a little increase in intraocular pressure, they concluded that it's safe and effective for the treatment of intermediate and posterior uveitis, and in fact, it is being used also for central retinal vein occlusion. When the efficacy of intravitreal corticosteroid devices was compared to other forms of treatment, and this is the only study in which it was really done in a prospective way, or at least in as prospective a way as possible, and this was the MUS research group, which many in the audience participated in, it was shown that there was no advantage to either treatment regimen. That is, whether you used intravitreal corticosteroids, or whether or not, such as delivered by Retisert, or whether you use systemic corticosteroids. So clearly, with the use of systemic corticosteroids, you had a similar efficacy as with intravitreal corticosteroids. If you look at the literature, there are very few reports of either implant in the control of birdshot chorioretinopathy. In 2011, Janet Davis and her group at Bascom Palmer Eye Institute had a retrospective case study of 22 patients whose medical records were reviewed. Treatment with Retisert was provided. And they looked at CME, vitritis, and retinal vasculitis and found that it was well controlled. However, the results of ERG and visual field were not analyzed due to wide variation among patients. That is, they couldn't find an effect on that. Other reports in the literature, there was an abstract in ARVO in 2011 with 3 eyes. There's a French manuscript that we actually went to the trouble of reading, although neither of us who prepared this program or prepared this presentation, and that's Dr. Puri, who's in the audience as well, it involves only one case. So really, the report really doesn't provide much insight. So our approach in terms of patients who have birdshot chorioretinopathy who we see for the first time is to use oral prednisone, either 1 to 1.5 milligrams per kilogram per day in divided doses, and that's for the initial control of the vitritis, CME, and retinal vasculitis. If they're intolerant of systemic corticosteroids or if they're non-compliant, then we consider either an implant such as Ozurdex or intravitreal Kenalog. And frankly, I prefer the latter. Intravitreal Kenalog costs $40 in the United States. That's with all the other charges associated with it. The Ozurdex costs $1,280. And I'm more than willing to give multiple intravitreal Kenalogs, if necessary, every 3 months for a comparison of $80 to $1,280. The question is, should immunomodulatory therapy, and specifically immune suppression or modified biologic response medications, be started concomitantly with corticosteroids? Well, in the United States, we face a problem. Unlike in Europe and other parts of the world, our patients' medical care is reimbursed by insurance, including Medicare, in which there's a copay. And if you're putting in a device which costs anywhere from $1,280, or some medications we have cost $2,100, that's a significant impediment for patients. And the insurance companies won't cover the cost of those higher medications. So unlike the experience you're going to see developed in Europe and elsewhere, except perhaps in a center, as I say, I'm really interested to find out how the insurance companies do pay for their for their biologic therapy. We can't get insurance companies to pay for biologic therapy for uveitis in general. It has to be associated with a systemic disease. So I think that's one issue that we have. As a result, to go back to what I was stating at the very beginning, we will put patients and maintain patients on immunosuppression for prolonged periods of time, and I think that's what inhibits the progressive loss of photoreceptor function. If then the patient transiently develops vitritis, retinal vasculitis, or CME, that's when we'll give steroid pulse, either intravitreal injection or even systemic injection, but for a short period of time. we're talking about doing it, you know, if we give it intravitreally, usually one injection. If we need to repeat it, we may repeat it in 6 weeks, but we usually don't need to. Or we'll give pulse therapy, which will last perhaps for a maximum of 2 weeks at the very high dose, and then we rapidly taper so they're off of it by 6 weeks. So I think that our approach to the treatment of this disease in many centers in the United States is going to be somewhat different than the approach you see reported in the literature from elsewhere in the world, but that's partly a consequence of the insurance mechanisms that we have. Thank you very much.